This is a presentation on evidence-based transfusion practice. I'm Dr. Tim Hannon, and this is part of our high-value care lecture series. Regarding disclosures, I am a consultant and the CEO of Healthcare Forward. So for this presentation on evidence-based transfusion practice, I'm going to integrate a case study. It's a real-world study on a patient for orthopedic surgery, a very common procedure. So in this case, it's a 87-year-old man for elective hip replacement surgery, one of the more common surgeries in the United States. His medical history is significant for having had a bypass surgery about 8 years ago. Fortunately, that surgery went well. He has no current cardiac symptoms and takes a daily baby aspirin. He also has hypertension, although well controlled, some impaired fasting glucose, and like a lot of 87-year-olds, has a remote history of smoking. With regards to his studies preoperatively, he had an EKG which was more or less non-contributory, non-specific ST changes. Important to note, he had no current cardiac symptoms with his daily activities, although because he has hip pain, he can't do as much as he used to. And importantly, the cardiology who did evaluate him did not see any need for further additional studies preoperatively. And as an anesthesiologist, that to me is the most important question, is not do they have cardiac disease, but do they need further studies or tune-ups. On his basic metabolic panel, he did have some mild renal insufficiency. As previously noted, a little bit of elevated fasting glucose, normal coagulation panels, and anemia, which again, not uncommon in this patient population. Hemoglobin of 11.2, normal would have been in the 13 to 14 range. Normal indices, but some low normal transferrin saturation, indicating most likely an iron deficiency and heme-negative stools. So based upon that history for this 87-year-old undergoing hip replacement surgery, what is your biggest medical concern preoperatively? Is it a history of cardiac disease, his history of high blood pressure, renal insufficiency, his glucose intolerance, or his anemia? The best answer in this particular case is anemia, although the other issues certainly do enter into his preoperative preparation and considerations for surgery and anesthesia. Anemia is the best answer, and we'll try to get to that through the course of this particular presentation. Of note, anemia is a significant risk factor for adverse events related to surgery. Anemia makes this patient more likely to get a blood transfusion, and we're going to focus on the risks of blood transfusions. And probably most pertinent to the discussion throughout the course of this lecture, anemia is modifiable. There are things that we can and should do for patients such as this that are having elective major surgery. Moving on with the case study, the patient had a uneventful intraoperative course, no problems with surgery or anesthesia. The estimated blood loss was 500 mLs, although I'll tell you, estimated blood loss is just that. We don't know very well as surgeons or anesthesiologists exactly how much blood loss there was because of irrigation, drapes, etc. Importantly, in this particular case, in major orthopedic surgery and spine surgery, a significant portion of the bleeding is actually post-operatively as the bones that have been fractured continue to bleed. On post-operative day number 1, he was noted to have some mild orthostasis, meaning he got a little bit lightheaded when he stood up, but it was readily treated with IV fluids and oral fluids. And on post-operative day number 2, his morning lab showed that his hemoglobin had decreased to 8.3. Remember, he was a little bit above 11 preoperatively, so he dropped about 3 grams. An important part of this story, which many of you may not know, is that 3-gram drop in hemoglobin after major hip surgery is expected and is normal because of this postoperative bleeding. This is called postoperative hemoglobin drift, as the patient has fluid shifts from surgery as well as some ongoing bleeding. So again, this would be considered a normal drop in his hemoglobin, and it would likely increase in the next day or two. So our second case study question is this. In this particular patient, with his history and his surgery, what is a reasonable postoperative hemoglobin transfusion trigger, assuming that he's otherwise asymptomatic, meaning we're just looking at that number and we're not concerned about his being unstable? Would it be 10 grams of hemoglobin, 9, 8, or 7? The best answer here would be a hemoglobin of 7, and I'll do my best through the course of this presentation to explain why I think 7 is the number. I would give partial credit for a hemoglobin of 8 based upon a large orthopedic study that was done, although it was done in hip fracture patients, called the FOCUS trial. So again, I believe the best number is 7, and hopefully by the end of this lecture, you'll agree with me. So now that we've set the table with a case study, let's talk about what is the evidence, best available evidence, for transfusion practice. Most of us know, whether we were trained last century or this century, that anemia is harmful. There are a variety of adverse events associated with anemia, in addition to the fact that patients who are anemic are closer to a transfusion threshold. But when we look at transfusing patients who are anemic, the most important question is, do patients get better when they're transfused? So anemia is harmful, but is there a therapeutic benefit of transfusions? From a historical standpoint, I just would note it's interesting that transfusions became common during the 1930s and 1940s with the advent of the ability to store blood products and, of course, World War II, but very little studies were ever done in terms of the effectiveness of transfusions, at least not until 1999. And in 1999, a landmark study was done, and it was called the TRIC trial, Transfusion Requirements in Critical Care, a prospective, randomized, large study in Canada comparing 2 different transfusion strategies in ICU patients, either transfusing patients at a hemoglobin of 10, which at the time was the standard of care for older, sicker patients, or transfusing them at a more restrictive level, in this case a hemoglobin of 7. Again, from a historical standpoint, interesting that the study was done because I'm sure there was some hesitation by physicians enrolling their patients with a concern that perhaps 7 was too low for this patient population. It turns out, based upon this large prospective study, that even in ICU patients, there was no benefit of being transfused at that higher hemoglobin level. In fact, most patients did at least as well or better being transfused at a hemoglobin of 7. And again, this was big news in 1999 because we had a presumption that older, sicker patients, in fact, needed higher hemoglobin levels. The conclusions of this study, which you can read, is the restrictive strategy of red cell transfusions is at least as effective and possibly superior to a liberal strategy in critically ill patients, with one possible exception. And that exception that they laid out were patients that were having either a MI or unstable angina. As a further explanation, it's not that they tested patients in this study that had unstable angina or were having heart attacks. They simply weren't included, but clearly they could not come to that conclusion based upon this single study. So this study, the TRIC trial, is ranked in the transfusion literature as the #1 study that has influenced transfusion medicine, and its impact is felt even today. Since 1999, there are well over 30 large prospective randomized trials using similar strategies, randomizing patients to either a liberal or a conservative strategy for transfusions with some variation in what those numbers were in a variety of patient populations. Understandably, after the ICU study came out, the TRICK trial, other patient populations, other specialists were certainly interested in would it apply to their patients, and then went on to do their own specialty studies. So this is a subset of those studies, and I'll try to just hit the high points. Published in 2006 was the PINT study, premature infants in need of transfusion. These were very sick, extremely low birth weight neonates that were randomized to one of two transfusion strategies. In this case, it was a hemoglobin of 12 versus 10, which are, again, relative thresholds in this patient population. And what that study showed is that there was no additional benefit of the higher hemoglobin threshold. In fact, the patients who were transfused at a hemoglobin of 10 did just as well. In 2007, a pediatric ICU study was done, also in Canada in this case, using a similar liberal versus conservative strategy. In this case, they chose a hemoglobin of 9.5 versus 7 and showed, once again, no difference in outcomes, no added benefit, so to speak, of higher transfusion thresholds, and importantly, a substantial reduction in transfusion exposure, about 44%. In 2010, a cardiac surgery study was published. It's the first of now 3 prospective randomized trials in cardiac surgery comparing a liberal versus restrictive strategy. In this case, it was a hematocrit of 30 versus a hematocrit of 24%, essentially 10 versus 8. Again, showing no difference in significant outcomes, but a substantial reduction in transfusion exposure. So the pattern that has emerged in these studies is that there is no added benefit of a more liberal strategy. And because we know that transfusions are scarce, hard to come by, and have significant risks associated with them, the preferred course of action with equivalent outcomes is more conservative therapy. I mentioned in the case study that there is one orthopedic study that has some bearing upon the case study, and it was called the FOCUS trial, published in 2011. Very large study, over 2,000 patients. The population was a little bit different. Rather than elective hip surgery, as is our case study, this was actually hip fracture patients, which is a very challenging patient population. I will tell you as an anesthesiologist, these are one of the more challenging patients that I manage because they are typically elderly. They are not prepared for surgery. It's a traumatic fracture that can bleed quite a bit. And the fact is that they often have comorbid conditions. And in this particular study, not only did they have to have a hip fracture and be elderly, the average age being 82, they actually had to have either cardiac disease or significant risk factors for cardiac disease. So again, tough patient population. In this particular case, they chose a threshold of 10 versus 8. One of the challenges in all of the studies that I'm mentioning is there is no clearinghouse that sets exactly what that number should be, 10 versus 8, 9 versus 7, etc. But they chose 10 versus 8. And importantly, in this very, very high-risk, challenging patient population, again, there was no difference in outcomes in the hospital. Perhaps even more significant, believe it or not, is there was no difference in functional recovery up to 60 days. The reason I mention that is that we were early adopters at St. Vincent, Indianapolis, my home hospital, for conservative therapy. We have a large orthopedic patient population, and our orthopedic surgeons were equally concerned about in-hospital outcomes as well as rehab potential. So, for example, if they could get through the surgery but couldn't rehab, it really doesn't do the patient justice. So in this particular study, important to note, no difference out to 60 days in rehab potential, even though they were transfused more restrictively. As a aside, although it's an important aside, there's a lot of disinformation in the orthopedic literature about hemoglobin levels and rehab potential. There seems to be reasonable concern that higher hemoglobins mean more rehab potential, but there's no evidence to back that up. In fact, if you blind the observer for hemoglobin levels and then test functional recovery, there doesn't seem to be a correlation. What is interesting, and it's more on the cardiology literature, is there seems to be a very good correlation between iron stores and rehab potential. Iron stores, of course, also lead to anemia or the improvement of anemia. So we're perhaps looking at the wrong surrogate marker. It's not just anemia per se, but iron deficiency is where we should be focusing in terms of treatment, not only to reduce transfusion exposure, but potentially to also improve rehab potential, which is, of course, incredibly important. Moving on, another study that I would certainly consider to be a landmark study, published in 2013, dealt with patients with acute upper GI bleeding. This is a patient population that was excluded in the TRIC trial. Remember, it was a stretch to even do that study with ICU patients, so they excluded patients who were actively bleeding. So again, very large study, almost 900 patients with acute upper GI bleed that were randomized to be either transfused at a hemoglobin of 9 or a hemoglobin of 7, so pretty aggressive criteria. Importantly, there were very few patients that were excluded here, only those patients who were massively being transfused, which is rare for GI bleed, or who in fact had low risk of transfusions based upon a pre-endoscopy score. And they encouraged single-unit transfusions in this patient population. I'd add one other factor that makes this important is that many hospitals are seeing an increase in GI bleeds, GI bleed admissions, largely by a combination of two factors. We have an aging population who is more susceptible to GI bleeds, and we have an increasing number of patients who are on novel oral anticoagulants such as rivaroxaban and apixaban, and these drugs are known to increase GI bleeds compared to warfarin. The results of the study were significant in that outcomes were better across the board in the restrictive category. Remember, many of the studies that we've talked about showed equivalent outcomes. This study showed superior outcomes in the restrictive group. There was substantially lower mortality at 45 days. There was a 4% absolute reduction in mortality. There were lower rebleeding rates, lower rates of emergency surgery, substantially shorter length of stay, and an overall lower rate of serious adverse events. So again, significant in this patient population with an aggressive transfusion threshold, better outcomes across the board. Interestingly, to me, in an editorial, when they looked at this study, they derived what's called a number needed to treat. So number needed to treat is typically used in healthcare economics to show the cost justification for a therapy that's layered in or a medical device. So if you look at a 4% difference in mortality rate, absolute difference, that translates into a number needed to treat of 25 patients. What that says is for every 25 patients treated with this more restrictive approach as opposed to the more liberal approach, you can actually save a life. And then trying to be, very concrete about this, if you are even a moderate size hospital, you admit at least 200 to 300 upper GI bleed patients a year. This could mean you could save somewhere between 8 to 12 lives a year using this more restrictive evidence-based strategy. So what I try to emphasize is, knowledge of this literature is really not an academic issue. It's a safety issue. We want to make sure that our patients have the benefit of the best available evidence. Another study that I'll hit because it was a point of controversy for some time is what's an appropriate transfusion threshold in septic patients. And most of you are aware that treatment of sepsis is a major focus across the United States. There was a study published some years ago, I think in the early 2000s. The lead author was Dr. Rivers, that used a transfusion threshold of 10 in the initial resuscitation of septic patients. It wasn't designed to be a transfusion trial, but because 10 was selected as part of the early protocol, many people thought that might be the best available evidence for sepsis. This particular study, published in 2014, I think lays that to rest. Again, a large study, 1,000 patients, 9 versus 7, aggressive transfusion strategy. Primary and secondary outcomes showed no difference in outcomes whether these patients were transfused at 7 versus 9. 50% reduction in transfusion exposure in the restrictive group, significant for all the reasons we've talked about, both saving blood and reducing potential complications. And it's important to note that although this, I think, definitively settles the answer, we know that the critical care community was already moving in this direction of a restrictive strategy for septic patients. The next study that I want to talk about, I'm going to do in a slightly different format. This is a study published by Mazur, was the lead author in the New England Journal in 2017. It's actually the third prospective randomized study in cardiac surgery, the best and the biggest of the three. But what I'm showing you is called a visual abstract. So visual abstracts were really generated by the Annals of Surgery looking for a way that they could get more engagement of literature by their membership. So traditionally, as a new article comes out, they can email the table of contents. They might put an abstract or a brief statement up on Twitter, Facebook, or wherever, but they found that not many people, based upon that, would actually go to the journal and read these articles. So what they came up with, I think, is pretty smart. This is an infographic that tells at a glance what are the major constructs of the study and the results. And then based upon this, people have more of an interest potentially in linking through this particular infographic to that particular article. In fact, a study was done that showed that the engagement rate goes up logarithmically by simply using this sort of an approach. So again, in this particular study, as I mentioned, this is cardiac surgery patients, over 5,000. Importantly, they had it as sort of a stressed model where they subselected patients who were known to be at moderate to high cardiac risk, so they excluded low risk based upon objective scores. Their transfusion criteria were either 7.5 versus 9.5. Here again, I'm not sure why it wasn't 7 versus 9, but it is what it is. And then they looked at, primary outcomes, which of course were death or major adverse events. The conclusion of this study, which echoes most of the other studies we've discussed, was no difference in outcomes. So in spite of the fact that they were high-risk cardiac surgery patients, there was no difference whether they were transfused at 7.5 versus 9.5. There, of course, was about a 30% reduction in transfusion exposure, which is also an additional benefit of this. And so once again, we have yet another very good study saying essentially less is more. If there's no additional benefit of more liberal therapy, we should really select the more conservative arm. One other last point about this study, published in 2017, this is consistent with the recommendations from the Society of Thoracic Surgeons, along with the Society of Cardiovascular Anesthesiologists. In 2007 and again in 2011, they recommended a restrictive strategy for perioperative transfusions in cardiac surgery. This, I think, just once again definitively gives us the answer. So that's a highlight of several of the major studies that have been done in different patient populations, showing that in fact a restrictive arm is at least as good, if not better, than a more liberal approach. But are there still open questions? And the answer is yes. So the first open category, although I think we're moving towards resolution, is oncology patients. I personally think it's a bit of an oddity that oncology didn't do a prospective study earlier because, as most of you would know, oncology patients are very heavily transfused because of chemotherapy, radiation therapy, etc. So this is a study that was presented at ASH and published in Blood back in 2016. They have not yet released the final version of it, but this is certainly a sneak peek, so to speak, of a study in oncology, and it was called the TRIST trial. So prospective randomized trial of 300 patients who are undergoing stem cell transplant. And the period between day 0 and day 100, of course, reflect their greatest risk of anemia. The transfusion strategies, again, very aggressive, a hemoglobin of 7 versus 9. Interestingly, the primary outcome was not adverse events, it was quality of life. And the reason I say that is that most people would not expect a lower transfusion threshold in outpatient oncology patients to lead to major adverse events, but certainly quality of life is a huge factor for patients as they go through the trials and tribulations of stem cell transplant and other cancer therapies as well. So the results of the study, again preliminary, they've not been formally released, but the abstract is out there, showed that in this high-risk patient population, those patients transfused at a hemoglobin of 7, of course, had a lower transfusion exposure, but very interestingly and very, I think, gratifyingly, actually had higher quality of life scores across the board. So no adverse outcomes, lower transfusion exposure, and the primary outcome, which is incredibly important for cancer patients, they actually had higher quality of life scores on the restrictive strategy. So again, I think we're moving towards having the answer definitively in oncology. And again, as a bit of an aside, the American Society of Clinical Oncologists, in their Choosing Wisely recommendations, has also recommended this more restrictive approach to red cell therapy. The last open question is patients with active cardiac disease. And again, there's some irony here because remember in the TRIC trial, their conclusions were that ICU patients do at least as good, if not better, being transfused at a hemoglobin of 7, but they simply couldn't call what we should do for ACS patients because they weren't studied. So here we are nearly 20 years after the TRIC trial, and unfortunately we still don't have a definitive answer. What we do have at this point is a fairly large number of observational or retrospective studies published in the cardiology literature by cardiologists that have looked at the association between transfusions and adverse outcomes using fairly sophisticated statistical methods like propensity scoring to try to match similar patients, but again, not prospective studies. All of those studies have shown the same thing, is that when patients with active cardiac disease, specifically acute coronary syndromes, having MIs or unstable angina, patients tend to do substantially worse when they are transfused versus not transfused. Again, surprising because we would certainly think that cardiology patients, among all patients, need the extra kick, so to speak, from a transfusion. We do not have the definitive prospective randomized trial. It is currently underway. It's called the MINT trial, M-I-N-T trial. Not certain when that will be completed or when the study will be published. But until it is published, we're left with, number one, observational studies like this, but number two, expert opinion of a number of societies, both in the United States and in Europe, that are recommending specific transfusion thresholds for cardiology patients. And to show you an example, this is one of a number of national guidelines that all look fairly similar. This happens to come from the United Kingdom, their most recent national guidelines. They recommend in most all patients a restrictive transfusion strategy, a hemoglobin of 7, except for patients with ACS. For patients with ACS, they say consider a hemoglobin threshold of 8, which seems to be the best available information until we have a definitive trial. But remember, this is the standard of care based upon component societies and best available evidence. And I think another important point here is they're also emphasizing single unit transfusions and reevaluate. Some physicians, many physicians in fact, that I've talked to over the years were taught informally that you need to transfuse patients in groups of 2, that if you give a single unit of transfusion, it simply does not get the job done. So 2 became the standard in many people's minds. It's not based upon prospective randomized trials. It certainly doesn't coincide with the concept of minimum effective dose, but many physicians think that 2 is the correct dose. We now know, based upon these guidelines, and we'll talk about some of the evidence, single unit transfusions is the correct dose in most all patients who are not actively bleeding. So where we are today, best available evidence is certainly, in general, less is more. 7 is the new 10, meaning that a hemoglobin of 7 is not only acceptable but preferred and recommended by a number of national guidelines, except for patients with active cardiac disease, and then the best evidence points to a hemoglobin threshold of 8.